Focus on nursing duties. Perhaps you should help with bedpans.
In the sterile corridors of St. Mary's Medical Center, the smell of disinfectant mingles with the quiet hum of life-saving machines. Here, where split-second decisions mean the difference between life and death, a black nurse named Angela moves with quiet precision, checking charts like she has for the past 8 years. No one knows she graduated summa cum laude from Johns Hopkins with dual degrees in nursing and pharmacology. No one even notices how her eyes catch medication errors that others miss, or how her gentle touch calms the most agitated patients. But when the prestigious cardiac surgeons struggle with a complex case, she observes from the shadows, her trained mind already identifying the problem they can't see. What they didn't know was that Angela had spent 5 years as a clinical research specialist at the National Institutes of Health, publishing papers on drug interactions that are still referenced today. And with just one quiet observation, she was about to expose a medical error that would have killed their patient. Because sometimes the person everyone overlooks is the only one paying attention. The morning sun cast long shadows through the hospital windows as Dr. Richard Montgomery, the chief of cardiothoracic surgery, swept into the ICU with his usual air of authority, his white coat pristine, his reputation untouchable. Behind him followed Dr. Sarah Chen, the resident eager to impress, and Dr. James Hartwell, whose family name graced the hospital's largest wing. "Patient in bed 7, Dr. Montgomery announced, his voice carrying the weight of decades in medicine. "Post-operative complications from the valve replacement. We're seeing unexpected cardiac arrhythmias." Angela, adjusting the IV drip for the patient in bed 6, couldn't help but overhear. Her trained ear caught something in the patient's labored breathing, something that made her pause mid-motion. "The medications aren't working as expected," Dr. Chen reported, flipping through the chart. "We've increased the dosage of amiodarone and added metoprolol, but the irregular heartbeat persists." Angela moved closer, her soft-soled shoes silent on the polished floor. Those medications, that combination. Her mind immediately went to the contraindications she'd memorized years ago, the dangerous interactions that most doctors never learned because they trusted the pharmacy systems to catch them. She whispered, almost to herself, "The calcium channel blockers." Dr. Montgomery's head snapped toward her, his eyes narrowing with visible irritation. "Excuse me? I was just—" "The patient's evening medications included amlodipine," Angela said quietly, her voice respectful but certain. "Combined with the amiodarone and considering his kidney function—" "Nurse Johnson," Dr. Montgomery interrupted with a condescending smile. "I think we can handle the complex pharmacology here. Perhaps you should focus on—" "Nursing duties," Dr. Hartwell chuckled, shaking his head. 8 years of medical school and residency, and we're getting medication advice from the nursing staff." But deep inside Angela, something had stirred. Not anger. She'd learned long ago to channel that into something more powerful. This was professional concern for a life hanging in the balance, and she knew what she'd observed was critical. If this story moves you, hit that subscribe button. We share incredible stories of overlooked heroes every week. Rate this story from 0 to 10 in the comments, and tell us about a time you witnessed hidden talent being dismissed due to bias. Your stories matter, and they inspire our next videos. Sometimes the most qualified person in the room is the one everyone assumes knows the least. Angela Marie Johnson had worked at St. Mary's for 8 years, arriving each morning at 6:30 a.m. to begin her 12-hour shift in the cardiac intensive care unit. She moved through her rounds with methodical precision, checking vitals, administering medications, updating charts, ensuring her patients received not just medical care, but the kind of human compassion that often made the difference between healing and merely surviving. The prestigious doctors walked by her as if she were part of the medical equipment, necessary but unremarkable. But Angela watched. She always watched. Her trained eye caught subtle changes in patient coloring, the slight irregularities in heart monitor rhythms, the way certain medications affected different patients based on their medical histories. On that Tuesday morning in October, Angela heard something that made her blood run cold. The conversation between Dr. Montgomery and his team about the post-operative patient wasn't just medical consultation, it was a prescription for disaster, and she was possibly the only person in that room who recognized it. The patient's creatinine levels have been elevated since surgery, Dr. Chen continued, reviewing the lab results on her tablet. But they're still within acceptable ranges for medication dosing. Those words weren't foreign to Angela. During her 5 years at the National Institutes of Health, she had specialized in exactly this type of drug interaction research. She had co-authored papers on cardiac medication protocols, particularly focusing on how kidney function affected drug metabolism in post-surgical patients. She moved closer to the nurse's station, pretending to update her charts while listening intently. The combination they were describing, amiodarone, metoprolol, with the patient's existing amlodipine prescription and compromised kidney function, it was a textbook example of the dangerous interactions she'd studied extensively. "Doctor," Angela said softly, approaching the group with careful deference, "I reviewed Mr. Patterson's complete medication history, and I noticed he's been on amlodipine for hypertension. Given his current kidney function and the amiodarone dosage—" "Nurse Johnson," Dr. Montgomery interrupted with barely concealed irritation. "Are you questioning our treatment protocol?" "No, sir. I'm just concerned about potential drug interactions that might be causing the arrhythmias rather than treating them." Dr. Hartwell exchanged a knowing look with Dr. Chen. "I'm sure you mean well, but complex cardiovascular pharmacology requires years of specialized training. Perhaps you should trust that we know what we're doing. Maybe you could help Mrs. Patterson in room 12 with her bedpan," Dr. Montgomery added with a smirk. "That seems more appropriate for your skill set." The dismissal stung, but Angela had endured worse. What troubled her more was watching Dr. Chen prepare another dose of amiodarone for Mr. Patterson, whose kidney function was clearly too compromised to metabolize the drug safely. The combination was going to cause toxic buildup, potentially triggering the very cardiac events they were trying to prevent. Angela walked away from the group, but this time something was different. This wasn't just embarrassment or frustration at being dismissed. This was professional alarm finally waking up. She had spent too many years studying pharmacology, had published too much research, had seen too many medication errors in her career to watch silently while a preventable tragedy unfolded. That evening, in her modest apartment 15 minutes from the hospital, Angela sat at her kitchen table with her laptop open. The screen displayed her LinkedIn profile, showing her credentials that none of her colleagues had ever bothered to learn. Master of Science in Nursing from Johns Hopkins, Graduate Certificate in Clinical Pharmacology, 5 years as a clinical research specialist at NIH, author of 12 peer-reviewed papers on cardiac drug interactions. She pulled up her research files, documents she hadn't referenced since leaving NIH to care for her mother during her cancer treatment. The data was clear, undeniable. The protocol Dr. Montgomery was following would likely kill Mr. Patterson within 48 hours if his kidney function didn't improve dramatically. Angela didn't cry. She had learned long ago that tears wouldn't save lives. Instead, she turned to her computer and started to work. She pulled up the latest research on post-surgical cardiac care, cross-referenced drug interaction databases, and compiled the evidence she knew she would need. "There it is," she whispered, looking at the data that confirmed her fears. It was always there. Wednesday morning arrived with the usual controlled chaos of shift change, but Angela could see immediately that Mr. Patterson's condition had deteriorated overnight. His heart monitor showed increasingly erratic rhythms, and his skin had taken on a grayish pallor that she recognized as a sign of cardiac distress. Dr. Montgomery's team still lingered around the nurses' station, voices growing sharper with each update from the overnight staff. His arrhythmias have worsened significantly, Dr. Chen reported, her usual confidence replaced by visible concern. The amiodarone doesn't seem to be controlling the irregular heartbeat, and we're seeing signs of decreased cardiac output. Increase the dosage, Dr. Montgomery ordered, his jaw set in determination, and add a calcium channel blocker to improve coronary blood flow. Angela felt her heart skip. They were about to compound the exact problem that was killing their patient. Without thinking, she stepped forward from where she'd been preparing morning medications. "Dr. Montgomery," she said, her voice steady despite the adrenaline coursing through her system. "Mr. Patterson is showing classic signs of amiodarone toxicity, complicated by his existing calcium channel blocker therapy. His kidney function isn't clearing the medications properly, and adding more calcium channel blockers will create a synergistic effect that could cause complete cardiac arrest." Dead silence fell over the group. 4 pairs of eyes turned to her with expressions ranging from surprise to outright hostility. "Are you seriously suggesting," Dr. Hartwell said slowly, "that we don't know how to read cardiac monitors or interpret lab values? I'm suggesting that the combination of medications, given his specific kidney function and the timing of his surgery, is causing toxic accumulation that's making his arrhythmias worse, not better." Dr. Montgomery's face flushed with anger. "Nurse Johnson, this is completely inappropriate. You're a floor nurse, not a cardiologist. You don't have the medical training to understand complex drug interactions in post-surgical cardiac patients." "Actually," Angela said quietly, "I do." The words hung in the air like a challenge none of them had expected. Dr. Chen laughed nervously. "I'm sorry, what exactly are you claiming? That you understand cardiovascular pharmacology better than board-certified cardiac surgeons?" Angela looked at Mr. Patterson, whose condition was visibly declining with each passing hour. She thought about her years of research, the papers she'd published, the lives she'd saved through her expertise in exactly this type of medication management. She thought about her mother, and the promise she'd made to always use her knowledge to help others, regardless of whether they respected her enough to listen. "I'm claiming that Mr. Patterson is going to die if you give him more amiodarone," she said, her voice carrying a quiet authority that surprised everyone, including herself. "His creatinine clearance indicates his kidneys are functioning at about 40% capacity. The half-life of amiodarone in patients with compromised kidney function extends from 25 days to over 60 days. He's been getting therapeutic doses for 3 days. The medication isn't failing, it's accumulating to toxic levels." Dr. Montgomery stared at her as if she had suddenly started speaking a foreign language. "Where exactly did a nursing degree teach you about amiodarone pharmacokinetics?" "The same place it taught me that combining amiodarone with calcium channel blockers in patients with compromised kidney function creates a 73% increased risk of sudden cardiac death within 48 hours of administration." The specificity of her response caught them completely off guard. These weren't vague concerns or intuitive worries. This was detailed pharmacological knowledge that most practicing physicians didn't possess. That's very specific," Dr. Chen said slowly. Angela walked away, but this time she didn't feel the familiar sting of dismissal. This time, she felt the weight of professional responsibility and the clarity that comes from knowing exactly what needs to be done. That wasn't just embarrassment or frustration finally waking up. That was her expertise demanding to be heard, regardless of the personal cost. In the supply room, Angela pulled out her phone and began making calls. She had connections at NIH, colleagues who would remember her work and validate her expertise. She had documentation that would prove her qualifications, and she had less than 24 hours to save Mr. Patterson's life. In her small apartment that evening, Angela sat with a framed photograph in her hands. The picture showed her standing in a laboratory at the National Institutes of Health, wearing a white lab coat with Dr. Angela Johnson, clinical research specialist, embroidered above the pocket. Behind her, sophisticated equipment used for cardiac drug research gleamed under fluorescent lights. On her coffee table lay a stack of medical journals, their pages marked with yellow sticky notes. Each publication contained her name in the author credits. Johnson, A.M., San Tien Benantorin. Cardiovascular drug interactions in post-surgical patients. Johnson, A.M., et al., renal function and cardiac medication. Metabolism. Her master's thesis from Johns Hopkins had been published in the New England Journal of Medicine and was still cited in current cardiac care protocols. Back then, this research was her life's passion. She had spent 5 years at NIH studying exactly the type of drug interactions that were now killing Mr. Patterson. Her work had contributed to updated FDA guidelines for cardiac medication dosing in patients with compromised kidney function. She had presented her findings at international conferences, had been recognized as one of the leading young researchers in cardiovascular pharmacology. The apartment felt smaller as she remembered the spacious laboratory where she had once worked, surrounded by colleagues who respected her expertise and valued her insights. Her research had prevented countless medication errors, had literally saved lives through improved protocols that hospitals across the country had implemented. But life had intervened in ways she never could have predicted. The phone call came on a Tuesday morning in 2016. Her mother had been diagnosed with stage 4 breast cancer. The prognosis was grim. 6 months to a year with aggressive treatment. Angela had requested extended leave from NIH to move back home and care for the woman who had sacrificed everything to put her through school. "You don't have to give up your career for me, baby," her mother had whispered during one of the chemotherapy sessions. But Angela knew what her mother had given up for her. Working 3 jobs to pay for her education. Never remarrying because she wanted to focus on raising her daughter. Postponing her own dreams so Angela could pursue hers. The leave of absence became a resignation when her mother's condition worsened. Angela moved back to their hometown and took a position at St. Mary's Medical Center, where she could work close to home and provide the round-the-clock care her mother needed. It was supposed to be temporary, just until her mother recovered or until she didn't. Her mother fought for 2 years, far longer than the doctors had predicted. Angela spent her days working at the hospital, and her evenings providing medical care that her nursing background had prepared her for, but her heart was never ready to deliver. She administered medications, managed pain, coordinated with specialists, and provided the kind of loving attention that no amount of medical training could teach. When her mother passed in 2018, Angela found herself emotionally and financially exhausted. The medical bills had consumed most of her savings. The idea of returning to research felt overwhelming after 2 years of grief and caregiving. So she stayed at St. Mary's, taking comfort in the familiar routines of bedside nursing, in the immediate satisfaction of patient care, in the quiet dignity of helping people heal. She never told anyone about her research background. The other nurses saw her as experienced and knowledgeable, but they didn't know about her publications or her NIH work. The doctors saw her as competent but unremarkable, just another floor nurse among dozens of others. The irony wasn't lost on her that she had returned to the exact type of clinical setting where her research was most desperately needed. Yet her expertise remained invisible to those who could implement it. She had become the overlooked professional she had spent years trying to protect through her research. But sitting in her apartment, looking at the evidence of her professional achievements, Angela felt something shift inside her. She didn't leave her expertise at NIH. Her knowledge never left her. She just had to step away from the spotlight for love, for family, for the kind of sacrifices that women, especially women of color in demanding professions, understand better than anyone. In that quiet apartment, surrounded by journals and photographs and memories of the researcher she used to be, Angela realized that expertise doesn't disappear just because others refuse to see it. Tomorrow, she would make sure they understood exactly who they were dismissing. The hospital was still wrapped in the quiet darkness of 4 a.m. when Angela stepped through the employee entrance. She had spent the entire night researching, documenting, and preparing a comprehensive analysis that would be impossible to dismiss. Her laptop bag contained printed studies, medication interaction charts, and a detailed treatment protocol that addressed Mr. Patterson's specific condition. She entered the ICU through the staff corridor, her badge granting her access to the unit where Mr. Patterson lay, connected to monitors that painted an increasingly dire picture. His heart rhythm had become more erratic overnight, exactly as she had predicted. The toxic buildup of amiodarone was reaching critical levels. Angela moved quietly to the computer terminal and accessed Mr. Patterson's electronic medical record. Using her nursing credentials, she documented her observations with clinical precision, noting the correlation between his medication schedule and the worsening cardiac symptoms. She included specific citations from recent research, detailed pharmacokinetic calculations, and alternative treatment recommendations. Then she did something that would change everything. Using the hospital's internal messaging system, she sent a detailed medical consultation to the overnight attending physician, Dr. Sarah Mitchell, who had just completed her cardiology fellowship at Mayo Clinic. Unlike the day-shift physicians, Dr. Mitchell had no preconceived notions about Angela's capabilities. The message was comprehensive and undeniably professional. Dr. Mitchell, I'm writing to express urgent concern about Mr. Patterson in ICU bed 7. Based on his medication history, current kidney function, and cardiac presentation, I believe he's experiencing amiodarone toxicity complicated by drug interactions. I've attached recent research and specific recommendations for alternative treatment protocols. This patient requires immediate intervention to prevent cardiac arrest. Respectfully, Angela Johnson, RN. Within minutes, Angela's phone buzzed. Dr. Mitchell's response was swift and decisive. Nurse Johnson, can you meet me at Mr. Patterson's bedside immediately? I have reviewed your analysis, and I need to hear more about these drug interactions. When Dr. Mitchell arrived, she found Angela standing beside Mr. Patterson's bed, quietly monitoring his vital signs. Walk me through what you're seeing, Dr. Mitchell said without preamble. His kidney function has been compromised since surgery, with creatinine clearance at approximately 40% of normal. Angela began, her voice steady and professional. Amiodarone has an elimination half-life of 25 days in healthy patients, but extends to 60-plus days with impaired renal function. He's been receiving therapeutic doses for 3 days, creating toxic accumulation. Dr. Mitchell pulled up the patient's lab results on her tablet. Continue. The combination with his existing amlodipine creates synergistic cardiac depression. Instead of controlling arrhythmias, we're seeing paradoxical worsening due to excessive calcium channel blockade combined with sodium channel effects from amiodarone toxicity. What's your recommended intervention? Discontinue amiodarone immediately. Begin activated charcoal to prevent further absorption. Initiate supportive care with temporary pacing if necessary. His natural rhythm should stabilize once drug levels decrease, which will take 48 to 72 hours given his kidney function. Dr. Mitchell stared at the monitor, then at Angela. How do you know this? I specialized in cardiac drug interactions for 5 years at the National Institutes of Health. I've published extensively on this exact scenario. The revelation hit Dr. Mitchell like a revelation. You're that Johnson. Angela Johnson from NIH. I cited your work in my fellowship thesis on post-surgical cardiac care. By 6 a.m., Dr. Mitchell had implemented Angela's treatment protocol. The amiodarone was discontinued, supportive measures were initiated, and for the first time in days, Mr. Patterson's cardiac rhythm began to stabilize. Word spread quickly through the hospital's medical network that a critical drug interaction had been identified and treated just hours before what would have likely been fatal cardiac arrest. Dr. Mitchell documented the case extensively, crediting Angela's expertise with preventing a sentinel event. The overnight nursing supervisor, Maria Santos, witnessed the entire intervention and immediately reported it to the hospital's Quality Improvement Committee. "This needs to go viral," Maria whispered to Angela as they watched Mr. Patterson's heart rhythm slowly return to normal. "Every doctor in this hospital needs to know what just happened here." Within hours, the story was circulating through the hospital's communication networks. Nurses shared it with other nurses. Residents discussed it during morning rounds. The medical director received a detailed incident report that would fundamentally change how expertise was recognized at St. Mary's Medical Center. Angela quietly completed her shift, but something was different. The monitors no longer just displayed vital signs. They displayed vindication. Thursday morning brought an unusual request. Angela was asked to attend a meeting in the medical director's conference room at 10 a.m. When she arrived, she found Dr. Montgomery, Dr. Chen, Dr. Hartwell, and several hospital administrators seated around the polished mahogany table. Dr. Patricia Williams, the medical director, gestured for Angela to take a seat across from the cardiac surgery team. Angela's laptop and several printed research papers rested on the table in front of her. "You wanted to know who I am," Angela said, her voice calm and professional. "So I'll tell you." Dr. Williams opened the meeting with directness that surprised everyone. "Nurse Johnson, we've pulled your personnel file and done some additional research. Can you confirm that you are Dr. Angela Marie Johnson, former clinical research specialist at the National Institutes of Health?" "I am." Dr. Montgomery shifted uncomfortably in his seat, his usual confident demeanor notably absent. "And you published 12 peer-reviewed papers on cardiac drug interactions between 2011 and 2016? 13, actually. The last one was published after I left NIH. Dr. Chen spoke up, her voice smaller than usual. "Why didn't you tell us about your background?" Angela looked directly at each physician before responding. "When exactly should I have mentioned it? When you dismissed my concerns about medication interactions? When you suggested I focus on bedpans? When you laughed about getting medical advice from nursing staff?" The silence in the room was profound. "I have a master's degree in nursing from Johns Hopkins University with a specialty in pharmacology. I spent 5 years at NIH studying exactly the type of drug interactions that nearly killed Mr. Patterson. My research contributed to the FDA guidelines that are supposed to prevent these exact scenarios." Dr. Williams consulted her notes. "Your research on amiodarone toxicity in patients with compromised renal function. That's currently cited in the American Heart Association's treatment protocols." "It is. So when you tried to warn the surgical team about Mr. Patterson's medication regimen, I was providing expert consultation based on 5 years of specialized research and clinical experience. The same consultation that any of you would seek from a pharmacologist or cardiologist if you bothered to respect the expertise." Dr. Montgomery finally found his voice, though it lacked its usual authority. "Why didn't you just identify yourself as a researcher?" Angela's response was measured but powerful. "Because I shouldn't have to present my credentials to have my professional observations taken seriously. A patient's life was at stake, and my expertise was dismissed, not because my analysis was wrong, but because you couldn't see past your assumptions about who I am." She opened her laptop and turned the screen toward the group. "This is my LinkedIn profile. My publications are listed here, along with my educational background and professional experience. This information has been publicly available for years. None of you bothered to look." Dr. Hartwell, who had been notably quiet, finally spoke. "We made assumptions." "You made racist assumptions," Angela corrected firmly. "You saw a black nurse and assumed intellectual limitations that don't exist. Your biases nearly cost a man his life." Dr. Williams leaned forward. What brought you to St. Mary's if you were conducting research at NIH? My mother was diagnosed with terminal cancer. I took leave to provide care during her treatment and final years. After she passed, I chose to remain in clinical practice because I found meaning in direct patient care. The weight of that revelation settled over the room. This wasn't a story of professional limitation or lack of opportunity. This was a story of sacrifice, of choosing family over career advancement, of expertise hidden by circumstance rather than lacking in ability. I didn't leave my expertise at NIH, Angela continued. My knowledge never left me. I just had to walk away from the spotlight for love, for family, for the kind of responsibilities that women, especially women of color in demanding professions, understand intimately. Dr. Chen's voice was barely above a whisper. We almost killed our patient because we couldn't see your qualifications. No, Angela corrected. You almost killed your patient because you refused to listen to medical expertise when it came from someone you didn't expect to possess it. In that quiet conference room, they finally saw Angela not as an overstepping nurse, but as the medical expert she had always been. The next morning, Angela stepped into the ICU like always, but everything had changed. The usual bustle of morning rounds was notably quieter, and she could feel eyes following her as she moved toward the nurses' station. Then Dr. Mitchell approached, followed by the entire night shift medical team. Dr. Johnson, she said formally, on behalf of the cardiology department, I want to thank you. Mr. Patterson's cardiac function has stabilized completely. Your intervention saved his life. A wave of applause began with the nursing staff and spread throughout the unit. Nurses, respiratory therapists, pharmacists, and even several residents joined in recognizing Angela's expertise. The sound echoed off the sterile walls, transforming the clinical environment into something warmer. More human, thank you, Angela said simply. But this is what we're all here to do. Save lives with the knowledge we possess. Later that morning, Dr. Williams called Angela to her office with news that would reshape her role at St. Mary's. The hospital board met in emergency session last night. We're creating a new position, Director of Clinical Pharmacology and Medication Safety. We'd like you to consider accepting it. The offer came with significant changes: a substantial salary increase, an office in the medical education wing, authority to review and modify medication protocols, and most importantly, direct consultation privileges with all departments. There's one condition, Angela said, her voice carrying the quiet authority that had emerged over the past few days. I want to maintain direct patient care responsibilities. I didn't return to bedside nursing just to climb administrative ladders. I want to keep touching lives directly while also preventing the systemic problems we just witnessed. Agreed, Dr. Williams replied, without hesitation. The following week, St. Mary's Medical Center announced the establishment of the Angela Johnson Center for Medication Safety and Clinical Excellence. The initiative would provide ongoing education for medical staff about recognizing and respecting diverse forms of expertise within healthcare teams. On the day of the announcement, the hospital's main auditorium was packed beyond capacity. Medical students, residents, attending physicians, nurses, and administrators filled every seat. Angela stepped up to the podium and looked out at the sea of faces. Some familiar, some new, all attentive. Excellence in medicine isn't just about individual knowledge, she began. It's about creating environments where all forms of expertise are recognized, respected, and utilized for patient safety. Every person in this room possesses knowledge that could save lives, if we're humble enough to listen and wise enough to look beyond our assumptions. She paused, her gaze finding Dr. Montgomery in the third row. He nodded slightly, a gesture of acknowledgement and respect that would have been unimaginable just weeks earlier. The most dangerous assumption in medicine is that expertise always looks like what we expect it to look like. Some of the most qualified people in our hospitals are the ones whose credentials we never bother to learn, whose insights we dismiss because they don't fit our preconceptions about who possesses advanced medical knowledge. Dr. Chen raised her hand. Dr. Johnson, what advice would you give to physicians about recognizing hidden expertise in our healthcare teams? Ask questions instead of making assumptions. When someone raises a clinical concern, investigate the merit of their observation before dismissing it based on their title or your preconceptions. The patient in bed 7 didn't care about anyone's credentials. He just needed the right medical expertise to save his life. The auditorium erupted in sustained applause. But Angela wasn't finished. This center isn't just about medication safety. It's about creating a culture where every healthcare worker feels empowered to contribute their expertise to patient care, regardless of their background or the assumptions others might make about their capabilities. She looked directly at the nursing staff seated throughout the auditorium. Your knowledge matters. Your observations save lives. Don't let anyone convince you otherwise. The entire room stood in thunderous applause that lasted several minutes. In that moment, Angela realized that her return to clinical practice hadn't been a step backward from research. It had been a step toward something more meaningful, changing the culture of medicine itself. As she left the stage, Dr. Montgomery approached her. Dr. Johnson, I owe you an apology that goes far deeper than professional courtesy. My behavior was inexcusable. Apology accepted. Dr. Montgomery, now let's focus on making sure this never happens to anyone else. 6 months later, Angela still arrives at St. Mary's Medical Center each morning, but now she splits her time between direct patient care and her role as Director of Clinical Pharmacology. Every morning, she makes rounds with the nursing staff while also reviewing complex cases with attending physicians who now seek her expertise rather than dismiss it. Her office walls display both her research publications and photos of patients whose lives have been saved through improved medication safety protocols. Young nurses and medical students regularly seek her guidance, not just about pharmacology, but about navigating professional environments where their expertise might be undervalued. Knowledge is power, she tells them during weekly mentoring sessions, but only when others are willing to recognize and respect it. Your job is to make that recognition impossible to ignore. Through the excellence of your work and the courage of your convictions, Mr. Patterson recovered completely and returns to the hospital monthly to volunteer with cardiac patients. He always stops by Angela's office to thank her, though she insists that gratitude belongs to the entire healthcare team that learned to listen. The Angela Johnson Center for Medication Safety has prevented 17 potential medication errors in its first 6 months, saving lives and improving patient outcomes throughout the hospital system. More importantly, it has created a culture where expertise is valued regardless of its source. Angela's story reminds us that the most qualified person in the room might be the one everyone overlooks. Brilliance doesn't always announce itself with credentials and titles. Sometimes it speaks quietly from the margins, offering insights that could change everything, if we're wise enough to listen. The real tragedy isn't when expertise goes unrecognized, it's when our biases prevent us from accessing knowledge that could save lives. Angela Johnson didn't need validation to be an expert. She just needed the opportunity to use her expertise where it mattered most. Sometimes the most powerful people are the ones nobody sees coming. What hidden talents are you overlooking in your own life? What expertise are you dismissing because it doesn't fit your expectations? Share your thoughts below. And remember, the next life saved might depend on recognizing the expert everyone else ignored.